Okay, let's dive into something that sounds, well, frankly, kind of insane when you first hear it. Imagine you go to a pharmacy right here in the U.S. You need a specific drug, maybe something life-changing like Ozempic, and bam, the bill is $1,500. But then, your neighbor, they literally drive maybe an hour across the border to Canada, same drug, same manufacturer, and they pay $147. How is that even possible?
Yeah.
Are we paying for, like, gold-plated syringes here?
It does sound completely absurd, doesn't it? But that's the reality for so many prescriptions in the U.S. Think about insulin, the actual cost to manufacture the raw drug, maybe $5,
Yeah.
seriously. Yet here, if you hit a coverage gap or you're uninsured, you could be looking at a $1,000 bill. That same vial in Canada, $18.
Okay, so my first thought is, the usual suspect, big pharma, greedy corporations. But hold on. If the drug makers are selling it for peanuts everywhere else, why are we the ones getting completely gouged? It doesn't quite add up.
And that's the fascinating part. We tend to think, oh, the system must be broken. But it's not broken at all. It's actually working perfectly. Just maybe not for you, the patient. We've been looking in the wrong place for the villain, so to speak. This crazy price difference. It's not just about R&D, not just the pharmacy counter. There's this invisible middleman, a kind of shadow player that's completely taken over drug pricing. They're called pharmacy benefit managers, PBMs.
PBMs, okay, I've maybe heard that term, but it sounds incredibly boring and bureaucratic, like something you'd ignore in your insurance paperwork. But you're saying they're central to this.
Yeah.
And invisible, but not small, right?
Our deep dive suggests these guys, collectively, make more profit than the top 10 drug companies combined.
That's right. More than the giants like Pfizer, Merck, all of them. It's staggering when you realize where the money's actually flowing. And yeah, for most people, a PBM is just jargon. So our mission today, let's pull back that curtain. Let's unpack how this hidden industry basically became the gatekeeper deciding what you pay for your medicine. Okay, let's start with how they present themselves. Because, on paper, they sound like the good guys. Their job description seems to be fighting for lower costs, right?
Exactly. They position themselves as the essential intermediary, the go-between, connecting the insurance company, the drug manufacturer, and the pharmacy. Think of them like a necessary toll bridge in the system.
Right. Okay, let's use an analogy. Imagine you want a $15 burger from your favorite spot. But before the order goes through, some guy in a suit steps in and tells the restaurant, hey, you got to pay me $5 first.
Yeah.
Or this person can't have that burger. That guy?
Yeah.
That's the PBM, the toll collector standing between you and what you need.
That's a pretty good way to put it, yeah. And their official role, the one they advertise, it sounds helpful. 1, negotiate lower drug prices from the manufacturers. 2, handle all the complex insurance claims stuff. And 3, supposedly reduce your out-of-pocket costs and save employers money. They promise savings. That's the pitch.
Okay, the promise. But the reality seems, let's say, different. How does this toll bridge actually make so much money?
Well, one of the main ways is something called spread pricing. This is kind of the core engine. Here's how it works. The PBM gets paid by your employer or your insurance plan for your medication. Let's say they charge the plan $100 for that drug. But then the PBM turns around and pays the actual pharmacy that gave you the drug. Maybe only $70.
Wait, what? So they charge the health plan $100, pay the pharmacy $70, and just keep the $30 difference.
Yeah.
That gap, the spread, is pure profit for doing
Right.
what exactly? Passing paperwork?
Pretty much. It's profit generated entirely in that middle space.
Well, hang on. Why would the pharmacy agree to take only $70? And why does the employer agree to pay the high $100 charge?
Yeah, well, that's where their market power comes in. The
Mhm.
pharmacy, like your local CVS or Walgreens, agrees to the low payment because if they don't join the PBM's network, they lose access to potentially 80% of the insured patients in their area. They basically can't survive if the PBM cuts them out. The PBM controls the flow of patients, so they get to dictate the terms to the pharmacy.
Wow. Okay, so it's almost like a protection racket. Nice pharmacy you got here.
Mhm.
Shame if something happened to your customer base. Just accept our lowball offer.
You could certainly see it that way. And the employers, the companies paying for the health plan, they accept the higher charge often because the PBM makes the whole thing incredibly opaque. They'll claim it's proprietary data or boast about their amazing negotiating power that justifies the cost. The employer thinks the PBM is working for them, trying to lower costs. But the PBM's real incentive is often to maximize that spread, maximizing their own profit.
Okay, so spread pricing is one piece.
Yeah.
That's already pretty bad. But then there's this other mechanism they use, right? Something that actually forces drug prices up. This sounds completely backward. It involves kickbacks.
Uh-huh. This is often called the rebate game. And yes, this is where you see that really serious artificial price inflation kick in. See, the PBM controls a critical thing called the formulary.
Formulary,
Sure.
that's the list. The list of drugs my insurance will actually agree to cover.
Exactly. If a drug isn't on that list, your insurance won't pay much or anything at all. It becomes unaffordable for most people.
So the PBM is literally the gatekeeper. They decide which drugs even get a chance to reach patients through insurance.
Precisely. Now, imagine you're a drug manufacturer. You desperately want your new drug on that formulary list, access to millions of insured patients. It's crucial. So to get on the list, the manufacturer has to offer the PBM a very large financial payment. They call it a rebate. But structurally, functionally, it acts like a mandatory kickback just for market access.
Hold on, let me get this straight. So if drug A is basically the same as drug B, maybe even cheaper to make, but the maker of drug B offers the PBM a bigger rebate, a bigger kickback. The PBM can then put drug B on the formulary and effectively block drug A, even if drug B is more expensive overall.
That's exactly how the incentive structure often works. The PBM is financially motivated to favor the drug that gives them the biggest rebate payment. It might not be the cheapest drug based on its list price, or even the most effective in some cases. It's about which one pays the PBM the most.
And this is what inflates the prices, because the drug company needs to afford the kickback.
Yes, it creates this totally perverse incentive. To afford that huge rebate the PBM demands, let's say it's $400 on a particular drug, the manufacturer has to set the initial list price of the drug artificially high. They need the list price to be, say, $1,000, just so they can pay the $400 rebate to the PBM and still cover their own costs and profit.
So the list price goes way up, purely to fund the middleman's rebate. And crucially, that rebate money, PBM just pockets it, right? They don't pass it back to my employer or to me at the pharmacy counter.
Generally, no. That rebate amount is often hidden. It's considered confidential business information between the PBM and the manufacturer. Your employer might get some rebate passed through, but often not the full amount, and you, the patient, your copay is usually based on that inflated list price.
Let's bring back the insulin example, that middle $1,000 list price. Are you saying like $300, $400, maybe even $600 of that is just noise, just money flowing around to feed this PBM rebate game?
The numbers vary, but yes, analyses suggest a huge chunk of the list price for drugs like insulin, especially branded ones, is directly related to these rebate dynamics. Hundreds of dollars per prescription potentially going straight to the PBM system, driving up the price everyone sees.
Wow. Okay, so the drug company gets its share, the PBM gets this massive hidden kickback, and me, the patient, I'm stuck paying a copay based on a fake, inflated price. And the poor local pharmacy is getting squeezed by spread pricing. It sounds like. Yeah, everyone loses except the PBM.
That's often the outcome, unfortunately.
All right. If that was the whole story, middlemen charging tolls and playing rebate games would be infuriating enough. But then comes the plot twist, like something out of a movie.
Yeah.
The PBMs apparently decided just collecting tolls wasn't enough. They wanted more.
They wanted to own the whole road, the toll booths, the gas stations, everything. This is the vertical integration piece. It's a huge shift. The three biggest PBMs, the ones controlling about 80% of all prescriptions filled in the U.S., they aren't just benefit managers anymore.
What are they then?
They've merged with or bought out other massive players. They are now these giant healthcare conglomerates. They own the insurance company and they own the PBM, and in many cases they own the pharmacies too.
Wait, they own the insurance, the middleman negotiating the prices, and the place where I have to buy the drug. How is that even legal? That sounds like the definition of a conflict of interest. They're negotiating with themselves.
It raises enormous questions. Look at the big three. Caremark, a huge PBM, is owned by CVS Health, which obviously owns CVS pharmacies. Express Scripts, another giant PBM, is owned by Cigna, an insurance giant, and runs its own massive mail-order pharmacy. And Optum Rx, the third major PBM, is part of United Health Group, another insurance behemoth, and runs its own Optum home delivery pharmacy.
So they can literally force patients, through the insurance plan they also own, to use the mail-order pharmacy they also own, even if my local pharmacist gives me better service or theoretically could offer a better price if they weren't being squeezed.
Yes, that's called patient steering, and it's a major concern. They can design the plan benefits to make it much cheaper or even mandatory to use their own pharmacies. It maximizes their profit across the entire chain. They've closed the loop.
Unbelievable. Has anyone tried to push back on this?
Right.
Regulators?
Well, yes. The level of market control hasn't gone unnoticed. The Federal Trade Commission, the FTC, recently sued the big three PBMs. The lawsuit specifically accuses them of using their power, including the rebate system, to artificially inflate the price of essential drugs like insulin.
Finally. And do they find evidence, numbers?
Oh, yeah. The FTC's investigation alleged staggering markups. They cited specialty drugs, things for cancer, HIV, marked up by over $7.3 billion, just siphoned out through these PBM practices.
$7.3 billion. It's hard to even wrap your head around that amount of money being added to the cost of vital medicines.
It is. And perhaps unsurprisingly, one of the PBMs turned around and countersued the FTC, claiming the statements were false and defamatory.
Of course they did. Wow. The nerve. But it shows how incredibly high the stakes are when you control the financial levers for 80% of the nation's medicine.
Absolutely. But the real-world consequence, the bottom line, always lands on the patient. You hear countless stories, people documented in reports, who get caught in this web. Their copay is based on that crazy list price. Their deductible is huge. They just can't afford it, and they literally have to make choices like walking away from medication they desperately need. We've reached a point where the corporate structure, the drive for PBM profit, can directly block access to care.
It's created this uniquely American problem, hasn't it?
Yeah.
Because we know the drug itself doesn't have to cost this much. So if our system results in $1,500 for something that costs $150 elsewhere, how do other countries avoid this mess?
Well, let's look back at Canada or many European countries. The fundamental difference. The government usually steps in to negotiate prices directly with manufacturers. There isn't this powerful private for-profit PBM layer playing the rebate game and inflating list prices. The negotiation is often centralized, transparent, and the goal is explicitly to get the lowest possible price for the country's citizens. PBMs, as we know them, just don't exist in that same role.
And here's the kicker, the real irony. The U.S. is the engine of global pharmaceutical innovation, right? We do incredible research, develop so many groundbreaking drugs first.
We absolutely do. We lead the world in R&D investment and bringing new therapies to market. But then other countries benefit from our innovation by negotiating reasonable prices, while we end up paying 3, 4, 5 times more for the very drugs developed in our backyard.
So we're basically funding the world's R&D and then paying a massive premium to use the results ourselves. That is the worst deal ever.
It certainly seems that way, although there are some glimmers of potential change. You hear talk about policies like a favored nations approach, where the U.S. would demand prices no higher than what other developed countries pay. The fact that these ideas are even being discussed at a federal level shows that the PBM's control and the resulting price distortions are finally getting some real attention.
Let's hope that attention leads somewhere. But, okay, let's recap the core takeaway here.
Yeah.
That astronomical price tag on your medicine. It's not just the scientists in the lab or the pharmacists behind the counter. There's this huge, often invisible, third player, the PBM, sitting right in the middle, controlling access and taking a massive cut, often by making the price higher. And you can't fix a problem if you don't even know who's causing it.
Exactly. And the vertical integration makes it even tougher. Even large employers, who technically have negotiating power, struggle to fight back because the PBMs control the data, control the network, control the pharmacies. They control the whole game.
So now you know. The invisible gatekeeper has a name.
Which leads to the final, maybe unsettling question. If the company that controls your insurance plan also controls the list of approved drugs, also negotiates the price with the manufacturer, often demanding a rebate for itself, and also owns the pharmacy you're forced to use, who exactly is left on the other side of that table? Who is actually fighting for you?